Have you ever been mid-yawn, maybe, or really biting down on something chewy and you feel that little click? Or maybe just a bit of discomfort right where your jaw connects?
Yeah, that little pop or click, it happens to a lot of people.
It seems so minor, right? But it makes you wonder what's actually going on in that joint. We sort of take it for granted. But this connection point, the temporomandibular joint, or TMJ, it's actually, well, an incredible piece of biological engineering.
Oh, absolutely. It's genuinely one of the most dynamic and complex joints in the entire body. Think about it. Eating, talking, even just making facial expressions, it's all orchestrated right there.
And it's fascinating how something so essential, so everyday, can be so intricate. And unfortunately for some people, it can also be a source of real pain and dysfunction.
Exactly, which is why we're doing this.
Right. So that's our mission for you today. We're diving deep into the TMJ, really trying to unlock its secrets. We'll look at the anatomy, which is pretty surprising in parts, understand the almost elegant way it moves.
Like a little mechanical ballet.
Yeah. And crucially, we'll explore what happens when things go wrong. You know, from those common aches to more serious disorders, and importantly, how they're treated now.
We're basically taking a really detailed medical chapter and pulling out the key insights for you, making it clear, maybe even highlighting some surprising facts along the way.
Sounds good. And our main source for this is Chapter 47, Anatomy and Pathophysiology of the Temporomandibular Joint by Fletcher, Pykuch, and Lieblich. It's a solid foundation.
It gives us a great framework to understand the basics and then some of the more complex issues.
Okay, let's get into it. This marvel of engineering. What makes the TMJ so unique compared to, say, your knee or elbow?
Well, fundamentally, it's not just a simple hinge. It's a really sophisticated structure. You've got the glenoid fossa, that's a little depression in the temporal bone of your skull. Then there's the condylar head, the top part of your mandible or lower jaw.
Go.
And nestled right between those is a specialized articular disc. Plus, you've got this whole network of ligaments and muscles controlling everything.
And I remember reading it. It has this dual classification, which sounds complicated anatomically.
Right. Anatomically, it's called a diarthroidal joint. That just means it allows a lot of free movement, guided by muscles and limited by ligaments.
Yeah.
And it's also a synovial joint.
Synovial meaning it has that special fluid.
Exactly. It's lined by a synovial membrane that produces this lubricating synovial fluid. Crucial stuff.
And functionally, it gets even more specific, doesn't it?
It does. Functionally, it's a compound joint. This is because, thanks to that articular disc in the middle, you actually have 4 articulating surfaces interacting, not just 2.
4 surfaces. Wow. Okay.
Yeah, the temporal bone, the mandibular condyle, and then both surfaces of that disc. This leads to its really unique classification as a jingly marthrodile joint.
Jingly mo. Say that again?
Jingly marthrodile, it's a mouthful.
Definitely a mouthful. But what does it mean?
It basically means it does 2 distinct things at once. Jingly mo refers to a hinge motion, like rotation, that happens in the lower part of the joint between the condyle and the disc.
Okay, hinge motion in the lower part.
And arthrodile refers to a sliding or gliding movement translation. That happens in the upper part, between the disc and the temporal bone. So it's this amazing combination of rotating and sliding.
Which gives it that incredible range of motion, I guess.
Precisely. And a lot of that smooth operation is down to the synovial fluid you mentioned. It's amazing stuff, basically an ultra-filtered version of blood plasma, but it's packed with hyaluronic acid.
Ah, hyaluronic acid, like in skincare.
Sort of, yeah. It gives the fluid really high viscosity, makes it super slippery, and it has 3 main jobs. Obviously, lubrication, but also cleaning up debris, kind of like a janitor.
Phagocytosis, right?
Right, phagocytosis. And it nourishes the articular cartilage, which is important because the cartilage itself doesn't have blood vessels.
And there's something really cool at how it lubricates under pressure, isn't there?
Yes, this is fascinating. There's a theory, well, more than a theory now, called weeping lubrication. When the joint is under load, like when you bite down hard, the cartilage actually squeezes out water. This makes the remaining synovial fluid at that specific contact point much more viscous, much thicker, and more slippery right when you need it most.
Wow.
It reduces the friction coefficient dramatically, like 14 times less friction than if the joint were dry. It's a brilliant self-regulating system.
Nature's engineering at its finest. Okay, let's look at the bones involved, the temporal bone first.
Sure. So the temporal bone provides the socket part of the joint up top. It has 3 main articular areas. First is the articular fossa, or mandibular fossa. It's concave, like a shallow disc.
You'd think that takes all the pressure.
You would. But here's the surprise. It's actually really thin. In dry skulls, you can almost see through it. So it's not the main stress-bearing area.
That is counterintuitive. So where does the force go?
It goes to the structure just in front of the fossa, the articular eminence. This is a much thicker transverse ridge of bone. This is designed to take the load during function. It's the major functional component.
Okay, the eminence, not the fossa. Got it.
Yeah. And you have to distinguish the eminence from the articular tubercle, which is nearby that doesn't articulate. And then even further forward, there's a flattened area called the preglenoid plane.
And the other side of the joint, the mandible.
Right, the lower jaw, the mandible. It articulates via the condyles, these rounded ends. You have two, obviously, one on each side. They're kind of U-shaped when you look at the whole jaw. And the condyles themselves form an angle of about 145 to 160 degrees.
How big are they?
They're fairly compact, about 15 to 20 millimeters side to side, and maybe 8 to 10 millimeters front to back. And there's a little depression on the inner or medial side called the pterygoid fovea. That's an important attachment point for one of the key jaw muscles.
Okay, bones covered. Now, that articular disc you mentioned, the star of the show.
Absolutely pivotal. It's made of dense, fibrous connective tissue. And here's a crucial point. It's non-vascularized and non-innervated.
Meaning no blood vessels, no nerves.
Exactly. Which is an adaptation, really. It means it can withstand significant pressure without bleeding or causing pain itself. Its main job, as we said, is dividing the joint into those two compartments, the upper and lower, allowing for both rotation and translation.
And you mentioned it has different zones.
It does, based on thickness. There is an anterior band, which is thickest, a central intermediate zone, which is the thinnest, and that's where most of the function happens under the eminence,
Right.
and a posterior band that's sort of medium thickness. But it's important to remember, despite these zones, it's all made of the same basic, dense, fibrous tissue.
And how does it stay in place?
Good question. It's attached around its edges to the capsular ligament, which surrounds the joint. And significantly, some fibers from the superior head of the lateral pterygoid muscle attach to it as well. These attachments keep it stabilized and ensure it moves smoothly with the condyle.
Okay, so disc, bones.
Yeah.
What about the other soft tissues? Ligaments and that retrodiscal tissue.
Right, the supporting network. Behind the disc, you have the retrodiscal tissue, sometimes called the bilaminar zone. Now, unlike the disc, this tissue is highly vascular and highly innervated. Lots of blood vessels and nerves.
Oh, so that's where pain might come from. And maybe the synovial fluid.
Exactly. It's a big contributor to synovial fluid production, and it has two layers, or laminae. The superior one has elastic fibers. It attaches back towards the ear area and acts like a gentle restraint, kind of pulling the disc back slightly.
Like a tether.
Sort of, yeah, preventing it from popping too far forward. The inferior lamina is made of tougher collagen fibers and connects the disc firmly to the back of the condyle, preventing excessive rotation of the disc on the condyle. It's really vital for protecting the joint.
And the ligaments. You said they're like passive restraints.
Precisely. They don't actively move the joint, they just limit how far it can go, especially at the extremes of motion. Think of them as safety checks. You have the functional ligaments first.
There.
The collateral or discal ligaments. These attach the disc medially and laterally directly to the condyle, like little straps. They're key for ensuring the disc and condyle move together as a unit.
Yeah.
Then there's the capsular ligament. It's like a fibrous envelope surrounding the entire joint, holding everything together and, importantly, containing that synovial fluid.
Keeps the lubricant in.
Right. And on the outside, the lateral aspect, you have the temporomandibular ligament, sometimes just called the lateral ligament. It actually has two parts. An outer oblique part limits how far the jaw can drop down.
Prevents dislocation downwards.
Essentially, yes. And an inner horizontal part limits how far the condyle can move backwards, which is crucial for protecting that sensitive retrodiscal tissue we just talked about.
Makes sense. Are there others?
There are also two accessory ligaments, the sphenomandibular and the stylomandibular ligaments. They're a bit further away, but still considered part of the system. They also act as passive restraints and can influence the axis of rotation during certain movements.
Wow. Okay, that's an incredibly intricate structure. The bones, the disc, the fluid, the ligaments. It all has to work perfectly together.
It really does. Which brings us nicely to the muscles, the actual movers and shakers that drive all this.
Let's talk about those. How many muscles are we talking about?
Well, technically, about 12 muscles on each side influence jaw movement in some way. But for the primary actions, we usually focus on the four main muscles of mastication, the big ones that attach to the ramus, the vertical part of the mandible.
And they can work together or independently?
Yeah, that's key. The pairs can work symmetrically, pulling evenly on both sides for simple opening or closing. Or they can work unilaterally, one side contracting differently from the other for actions like chewing or moving the jaw side to side.
Let's break down the main groups, the supramandibular ones first. They mostly lift the jaw, right?
Primarily elevators, yes. You've got the temporalis muscle, that big fan-shaped one on the side of your head. It elevates the mandible to close the jaw, helps pull it backward slightly, that's retrusion, and helps move it to the same side, ipsilateral deviation. It's more about control than raw power, though.
So which one provides the power?
That would mainly be the masseter muscle. It runs from your cheekbone down to the angle of your jaw. It's often called the most powerful elevator, generating the force needed for chewing tough foods.
And you mentioned something surprising about its layers.
Yes. It has a superficial layer and a deep layer, and research shows they can function independently, even reciprocally. For example, during protrusion moving the jaw forward, the superficial part might be active while the deep part is silent. But during forceful retrusion, the deep part might kick in strongly. It's much more sophisticated than just one big clamping muscle.
Fascinating. What else is in that elevated group?
The medial pterygoid muscle is sort of the internal counterpart to the masseter. It also elevates the mandible and helps with protrusion, especially unilaterally.
Okay. And the last one of the big four, the lateral pterygoid. That one's unique.
Very unique. It has two heads, a superior and an inferior head. And the really interesting thing is that these two heads function independently and reciprocally. They often do opposite things at the same time.
How does that work?
Well, the inferior head is the main muscle for protrusion, pulling the condyle forward and down the eminence, which helps initiate jaw opening. It also pulls the jaw towards the opposite side.
Okay. Inferior head opens and moves contralaterally.
Right. The superior head, on the other hand, is mostly active during closing, acting to stabilize the condyle and disc against the eminence. It also helps pull the jaw back, retrusion, and move it towards the same side, ipsilateral movement. This push-pull coordination is vital for smooth, controlled movement.
Incredible coordination. And briefly, the muscles that open the jaw, the depressors.
Yeah, the inframandibular group. These include the suprahyoid muscles like the digastric, geniohyoid, mylohyoid, stylohyoid, and the infrahyoid muscles below the hyoid bone. Their job is either to pull the mandible down directly or, very importantly, to stabilize the hyoid bone so the suprahyoids have a firm base to pull against when opening the jaw.
So it's a whole system working together. How does this translate into the actual movements we make, the biomechanics?
Well, the complexity comes from the fact that you're essentially coordinating four joints simultaneously, the left and right TMJs, each with its upper and lower compartment.
Right, those two types of movement we talked about.
Rotation and translation, exactly. Rotation is that hinge-like motion. It happens mainly in the inferior joints between the condyle and the disc. You can actually get about 2.5 centimeters of opening at your front teeth just by pure rotation, like a simple hinge.
But we can open much wider than that.
We can, and that's where translation comes in. Translation is the gliding or sliding motion. It happens primarily in the superior joints, between the disc condyle complex and the temporal fossa and eminence. This allows the entire mechanism to move forward and down. Maximum forward or lateral movement is about 1.5 centimeters.
And in normal function, like talking or chewing.
They happen together. Rotation and translation occur simultaneously, smoothly blending to allow the full range of motion needed. It's not usually one, then the other. It's a coordinated combination.
Driven by the muscles.
Absolutely. It's the continuous, finely tuned activity of those mastication muscles, particularly the elevators like the masseter and medial pterygoid, that keeps the condyle and disc properly positioned and in contact with the eminence throughout the movement. The ligaments, remember, are just the safety nets at the end of the range.
Okay, a truly complex and elegant system when it's working well. But inevitably, sometimes things go wrong. Let's shift focus to TMJ disorders, or TMJD. How common are these problems?
They're surprisingly prevalent. Studies suggest at least 5% of people experience jaw pain significant enough to be clinically relevant, and maybe around 2% actually seek treatment for it.
What causes TMJD? Is it one specific thing?
That's the tricky part, usually not. It can stem from muscle issues like hyperfunction or parafunction, think clenching or grinding, bruxism.
Stress-related habits, often.
Often, yeah. Or it could be due to underlying degenerative changes within the joint itself, like arthritis. But honestly, no single cause has been definitively proven to be the factor. It's often multifactorial.
So how are they generally classified?
Broadly, you can divide them into non-articular, meaning the problem is mainly with the muscles, and articular, where the issue is inside the joint structures themselves.
Let's start with the non-articular, the muscle side.
Okay. Masticatory muscle dysfunction probably accounts for half, maybe even more, of all TMJD cases. This can range from an acute muscle strain or spasm, maybe from opening too wide or chewing something really tough,
Yeah, I can imagine that.
to more chronic conditions like myofascial pain and dysfunction, or MPD. This often involves trigger points in the muscles and referred pain, and it's frequently linked to those parafunctional habits: grinding, clenching.
Is that related to fibromyalgia at all?
It can be difficult to differentiate sometimes. Fibromyalgia is a systemic condition affecting the whole body with widespread pain, fatigue, poor sleep. It tends to affect women more, often in an older age group than typical MPD. So there can be overlap in symptoms, but the underlying condition is different.
And how are these muscle-related issues typically treated?
The good news here is that non-surgical approaches are really the standard of care and are often very effective. Things like occlusal adjustments, minor bite changes, or using night guards or splints.
To stop the grinding.
Exactly, or at least manage the forces. Also, non-steroidal anti-inflammatory drugs, NSAIDs, sometimes muscle relaxants for acute spasms, and physical therapy, stretching, exercises, modalities like heat or cold.
Okay, so conservative treatment first for muscle issues.
Yeah.
What about the articular problems issues within the joint?
Right, articular TMJD. Here we often see non-inflammatory arthropathies, with osteoarthritis being the most common. This isn't necessarily like the inflammatory arthritis elsewhere. It's more wear and tear degenerative changes.
What does that look like inside the joint?
It can involve chondromalacia, which is softening of the cartilage. A very common finding is disc displacement, where the disc isn't sitting correctly on the condyle anymore. There's actually a classification system, Wilks stages I through V, describing how severe the displacement and degeneration are. You can also get bony changes and fibrosis, scarring within the joint. And this can sometimes happen after trauma or an infection.
And can it become inflammatory?
Yes. If the inflammation is obvious, then we call it an inflammatory arthropathy. This could be synovitis inflammation of that synovial lining, or capsulitis, inflammation of the capsule. Systemic diseases like rheumatoid arthritis can also directly affect the TMJ. And sometimes the non-inflammatory type can progress to an inflammatory one because the breakdown products from degenerating tissue can trigger an inflammatory response.
Now, you mentioned earlier a big shift in understanding why this happens, beyond just wear and tear.
Yes, this is where things get really interesting at the molecular level. The understanding of TMJD pathogenesis has fundamentally shifted from just looking at the anatomy changing to understanding the molecular biology driving those changes.
Okay.
It comes down to a balance. In a healthy joint, there's a balance between anabolic factors, cytokines that signal the joint to build and repair its matrix, and catabolic factors.
Build versus breakdown.
Exactly. Anabolic cytokines like IGF-I and TGF-beta promote building. Catabolic cytokines like interleukin-1, IL-1, IL-6, and tumor necrosis factor alpha, TNFI, promote breakdown by activating enzymes called proteases that literally chew up the joint tissues.
So in TMJD.
In symptomatic joints, that balance is tipped. The catabolic destructive processes start to dominate. And it's not just those cytokines. Oxidative stress plays a big role too. It leads to free radical formation, which further amps up the destructive signals and enzymes. It becomes a vicious cycle of tissue destruction.
And you can actually measure this.
Yes. Analyzing the synovial fluid, the joint fluid itself, has become an incredibly powerful diagnostic tool. Studies consistently show that in diseased TMJs, you find higher levels of those catabolic markers: IL-1, IL-6, active proteases like matrix metalloproteinases. You also see increased levels of chondroitin and keratin sulfates, which are breakdown products of cartilage.
Wow.
Conversely, protective factors like something called OC-FOPBG, which normally inhibits bone breakdown, are often found at lower levels in diseased joints. So, analyzing the fluid gives us a direct window into the molecular chaos happening inside, really shedding new light on the pathogenesis.
That's a huge leap in understanding. Now let's touch on infections. You said they're rare.
Thankfully, yes, true infections of the TMJ are rare, but they're serious when they happen. A patient might present with severe pain, maybe warmth or swelling over the joint. A key sign can be a posterior open bite on that side, meaning the back teeth don't meet, and they might hold their jaw shifted towards the opposite side.
How do infections usually get in there?
Often through the bloodstream hematogenous spread. Remember that synovial lining is highly vascular, but lacks a protective basement membrane, making it somewhat susceptible. Infections can also spread directly from nearby dental infections or from direct trauma like a penetrating injury.
Are there specific bacteria usually involved?
Yes. For acute infectious arthritis in general, especially in sexually active adults, Neisseria gonorrhea is a major player, though it only involves the TMJ in a small percentage of those cases. In young children, Haemophilus influenza used to be common, though vaccines have reduced that. Otherwise, common skin and mouth bacteria like Staphylococcus and Streptococcus are frequent culprits.
Any other specific infections to be aware of?
Lyme disease is important to mention, particularly in endemic areas like the northeastern U.S. It's been documented as a cause of TMJ infection. Patients get acute pain, can barely open their mouth, and often have migratory arthritis affecting other large joints too.
So if infection is suspected, what's the approach?
Quick action is critical. The standard procedure is to aspirate fluid from the joint, stick a needle in, and draw some out. That fluid gets sent for a gram stain, culture to identify the bacteria, a white blood cell count, which is often very high in septic joints, over 50,000, and crystal analysis to rule out gout or pseudogout.
And treatment.
Immediate aggressive treatment, usually starting with intravenous antibiotics, broad-spectrum ones initially, like ampicillin and sulbactam, then tailored once the specific bacteria is known. Often combined with joint lavage, washing out the joint, and crucially, starting active range of motion exercises early to prevent the joint from stiffening up or even fusing, which is called ankylosis.
Okay, rare but serious. What about neoplastic diseases, tumors?
Even rarer in the TMJ itself. The main danger here is that because they're so uncommon and the symptoms like pain or dysfunction can mimic common TMJD, the diagnosis might get delayed. And delay is bad, given how close the TMJ is to the base of the skull.
Are there benign types?
Yes, benign tumors are more likely than malignant ones. Things like osteoma, a benign bone growth, or just general condylar enlargement or hypertrophy. These usually cause the condyle to get bigger, shifting the jaw to the opposite side and creating an open bite on the affected side.
Any others?
Synovial chondromatosis is probably the most common synovial neoplasm. Here, the synovial lining starts producing little bits of cartilage metaplastically, which detach and float around in the joint space as loose bodies, often in the upper compartment. Treatment involves surgically removing those loose bodies and the abnormal synovial lining.
And malignant tumors.
Extremely rare primary tumors of the TMJ. When malignancy affects the TMJ, it's usually either an extension from a nearby cancer or, more commonly, metastatic disease cancer that's spread from elsewhere. Common sources are adenocarcinomas from the breast, kidney, or lungs. These typically occur in older patients. Treatment has to be aggressive, radiation, surgery, chemotherapy because of the risk of intracranial spread.
Okay, so a whole spectrum of potential issues. Let's wrap up with treatment modalities for TMJD in general. Where do doctors usually start?
Almost always start conservatively, non-surgically. As we mentioned, for the muscle disorders, this includes things like bite appliance therapy, splints, night guards, modifying the diet to reduce stress on the joint, NSAIDs for pain and inflammation, sometimes muscle relaxants using moist heat or ice, and physical therapy. These methods have a really good track record of success for many patients.
And if those don't work?
Then you might consider minimally invasive surgical options. Arthrocentesis, which is basically just flushing the joint out with needles, and TMJ arthroscopy using a small camera and instruments inserted into the joint have proven very effective for reducing pain and improving motion, especially for things like acute closed lock where the jaw gets stuck, degenerative joint disease, or when there's significant joint effusion, excess fluid.
And why does just washing out the joint help so much?
That goes back to the molecular understanding. The hypothesis is that lavage, the washing out, physically removes many of those inflammatory mediators and destructive enzymes, those catabolic cytokines and proteases we talked about. By flushing them out, you're altering the biochemical environment inside the joint, hopefully shifting the balance away from destruction and towards a more anabolic healing state.
Ah, cleaning house at the molecular level.
Kind of, yeah. And finally, if those minimally invasive options fail or aren't appropriate for the specific problem, like severe bony ankylosis, a tumor that needs removal, or really advanced degenerative disease requiring reconstruction, then open joint surgery or arthrotomy might be considered. But it's generally reserved for more complex cases due to higher potential morbidity compared to arthroscopy or arthrocentesis.
Wow, what a journey through the TMJ today. It's been fascinating. We've gone from its surprisingly complex structure, the jingly morphoradial classification,
Still a mouthful.
through the intricate dance of its muscles and ligaments, and into the wide range of things that can go wrong, from muscle strain to rare tumors.
Yeah.
And crucially, understanding that huge shift towards looking at the molecular level for both diagnosis and potentially treatment.
It really underscores that the jaw isn't just a simple hinge at all. It's this incredible piece of biological engineering.
Yeah,
And appreciating its complexity, I think, helps us understand not just TMJ disorders, but also the amazing advancements happening in medical science to figure these things out.
absolutely. Which leads us to a final, maybe provocative thought for you, or listeners, to consider. Given these incredible strides in understanding the molecular basis of TMJ disorders, the cytokines, the enzymes, the oxidative stress, what might the future hold for preventing these issues?
That's a great question.
Could we, perhaps one day, identify individuals at high risk based on their joint fluid biochemistry, maybe even before they have symptoms? And could we intervene then perhaps with targeted molecular therapies or even personalized bioengineered solutions to rebalance the joint environment and stop the damage before it truly begins? What do you think?